Okay, good evening. This is Joe Gallo of ANCAN, and I should add more than good evening because our registration, we have about 535 registries, and that includes people from Europe, Canada, definitely all across the United States. So for wherever you are, good day, good afternoon, or whatever. Glad you could join us. We'll get right into this, but I want to hit a couple of administrative points first off to make sure that everybody's there. If you, on your reminder, you did get an indication where you can get some information on how to use the control panel, which is typically off to the right side of your screen. The main thing that you will be interested in is submitting questions. You can submit questions throughout the presentation, and then they'll be consolidated and presented to Dr. Epstein after his presentation. We also would like to acknowledge our co-sponsors. Our primary co-sponsor is US2. We also have additional co-sponsors of PCRI, PCI, Zero, the End of Prostate Cancer, and Cancer ABCs. All of these people have contributed in helping to get this organized and off the ground. I will mention that for questions, and I'll mention it again when we get to the Q&A portion of it, the questions, you please don't make them too personal. If they're too personal, we're not going to be able to try to get into the business of doing diagnostics. That's not the object tonight, but more of information sharing. The other question that had come up once before was, well, do we take the audience questions? What we do is we take the audience questions that you're submitting now, plus we did get a significant input via the email, and the different questioners will be trying to consolidate those to make sure that we make the best use of our time. And I think that pretty much covers the main things that we need to handle. We will then move on to greetings. Rick Davis, the founder and head of ANCAN, is here, and Jim Straight, who is also, I'm not sure what your title is right now, Jim, but you're sort of the honcho of US2.
For one more day, I'm chairman, then I'm immediate past.
Okay. So Rick, you're on for about a minute, and then if you could hand it off to Jim, and then we'll come back.
Welcome everybody. We are truly honored to receive Dr. Epstein tonight. He is probably one of the most famous of all of the prostate cancer docs across the board. He's touched so many lives in so many different ways, and it's an honor to have him here. It's also an honor to have all of you out there, and on behalf of ANCAN, we want to wish you a very safe and a very healthy 2021. Check out, if you're living with prostate cancer, check out our groups on ancan.org and come join us in one of the 12 prostate cancer groups, virtual groups that we offer each month. I will pass this on to about to be immediate past chair, my good buddy, Jim Straight.
Thank you, Rick. As I come to the end of my term as chair of US2, it's an honor and a privilege to be here tonight. And we're so happy to have the opportunity to co-sponsor this series of webinars with ANCAN. I think they've been fantastically successful, not only in terms of numbers of registration and participants, but just the outstanding quality of the presentations. It's been a real privilege to work with ANCAN. Concerning Dr. Epstein, I've been a member of a support group now for almost 11 years, and I've been the facilitator of that group now for about 5 years. And probably the one piece of advice that we have given most often to patients is get a second reading of your slides and send them to Dr. Epstein at Johns Hopkins. So it's a thrill and a privilege for me to be able to meet Dr. Epstein tonight virtually, and I think you're in for a great program. So thank you for joining us, and best wishes for the new year.
Okay, and before I hand it off to Howard, I have one more administrative point that I forgot, because some of you folks have come in on just telephone, so you won't be able to see the presentation on the screen. However, on your acknowledgement, the reminders that you received over the past couple of days, or you can go to the ANCAN site, you can get to view the slides as well. So they're posted out there so you can follow along with us. And with that, I will turn it over to Howard.
Okay, well, again, we're honored to have Dr. Epstein as our speaker, closing our first season of active surveillance and beyond. And our support group, almost on a weekly schedule, we share Dr. Epstein's name and email address for people looking for second opinions. Now, Dr. Epstein may be the hardest working pathologist in the world. He reads 12,000 cases, not slides, per year. He has played a role in every major happening involving surgical pathology, at least pathology for prostate cancer. He's a professor of pathology, urology, and oncology, and director of surgical pathology at Johns Hopkins Medical Institutions. He trained at Hopkins with a fellowship at Memorial Sloan Kettering Cancer Center in New York. He's past president of the International Society of Urological Pathology. And, you know, a lot of you know of Dr. Klotz, who has been a pioneer in active surveillance based out of Canada. He describes Dr. Epstein as, quote, the inheritor of Gleason's mantle as the premier prostate cancer pathologist in the world, end quote. So that's high praise. So with that, I'll shut up, and it's Dr. Epstein's turn.
So I want to thank everybody for the invitation. It truly is an honor for me to be here. So tonight, what I'm going to be discussing is the critical role of pathology in active surveillance, and describe both the critical role of pathology for criteria and definition of progression. So the outline of what I'm going to be discussing is first, I'm going to introduce the Gleason system and discuss basically what we see under the microscope. So when you hear words like Gleason 6 or Gleason Pattern 3, Gleason Pattern 4, Cribiform Glands, etc., what that means. And I'll show you examples and try to explain it so that you get a better handle of what we're looking under the microscope and what these terms mean for you. I'll talk about criteria for selection for active surveillance, the trigger for intervention on active surveillance, and some of the changes that I've been involved with and how we report grade and their impact on active surveillance. So in terms of the pioneers of the Gleason system, there was Donald Gleason, who was the head of the Department of Pathology at the Veterans Hospital in Minnesota. There was George Mellinger, who was the head of the Department of Urology at the Minneapolis Veterans Hospital. And there was John Bayer, who was a statistician. And that's Donald Gleason to the far left, who's since deceased. And this is the Donald Gleason's iconic Gleason schematic diagram on the left, where they had patterns 1, 2, 3, 4 and 5, 1 being low grade, 5 being very aggressive. And what Gleason came up with, which was unique for any cancer system, was not taking the worst grade that they saw under the microscope and saying that was the grade for the tumor, but noted that the prognosis was best matched by looking at what the most common grade was and adding it to the second most common grade to arrive at a total of a Gleason score. So let me go back to, so this is Gleason pattern 3. You're going to notice that tonight I'm not going to be mentioning Gleason patterns 1 and 2, even though that's something that Gleason came up with and talked about. As I'll talk about at the end of the lecture, in the new grading system, we no longer diagnose Gleason patterns 1 and 2. So basically, patterns 1, 2, and 3 are all considered together as one grade. We call them Gleason pattern 3 today. And if a whole tumor is pure, we call it grade group 1. And again, I'll talk about that later. But the key thing to recognize is that grading has changed dramatically. So Gleason's prostate cancer grading development was in the late 1960s and early 1970s. And if we look at back what Gleason had, they included a lot of patterns that we would call Gleason pattern 4 today, such that back then, if you had a Gleason score of a 3 + 3 = 6, there were patients who died of these cancers, and they were some extremely aggressive back then, Gleason 3 + 3s. We're now going through several evolutions of prostate cancer grading, and on the screen on the right is basically what we see currently. And what we see with Gleason pattern 3 now, as I'll talk about, is a very uniform population where patients typically have a uniformly good prognosis if that's what their entire tumor looks like. So this is under the microscope what Gleason pattern 3 looks like. And what I've done is the definition of these Gleason pattern 3 are individual, well-formed, discrete glands. So the way to think about it, think of a gland as basically an inflated basketball filled with air. And if you were to take a slice through that basketball, take 2 parallel slices, you would end up something looking like a donut, which is basically what you have here outlined in this black, a circle. And then the internal part of that basketball, which you've sliced, would be a lumen, or what we call a lumen. So in a well-formed Gleason pattern 3, you have these glands, which in three dimension are spheres, are balls, basically empty balls, with a nice well-formed lumen in the middle, which I've drawn here in the center. So this is Gleason pattern 3. Gleason pattern 4 has evolved. So many of the patterns that in the past, Gleason would include in pattern 3 are now shifted to Gleason pattern 4. So again, what that means for the patients is that tumors now who have a pure Gleason pattern 3 have an excellent prognosis, where in the past it wasn't as pure as a prognosis. And many of the patterns 3 in Gleason have now moved down to Gleason pattern 4. And I'll talk about a little bit more the different patterns of 4. So when you talk about different patterns of 4 under the microscope, and this will become important later when we talk about some relatively new information that's important prognostically, there are different patterns of 4. There's only one type of pattern 3, those are individual well-formed glands. But within pattern 4, you can have poorly formed glands, fused glands, and cribiform glands. And the word cribiform derives from the Latin word of sieve, or like a colander. Now, what you'll notice also is the well-formed glands of Gleason pattern 3 basically try to resemble or recapitulate what normal prostate glands look like. And that makes sense for a Gleason pattern 3 to have a good prognosis. It's a tumor that's what we call well differentiated. It's trying to resemble normal glands. Whereas we're starting to look in pattern 4, the glands start to have a greater deviation from what normal glands look like. So these are poorly formed glands of Gleason pattern 4. So if you see the outer circles that I've drawn, they're still individual glands, but instead of having a nice donut hole in the middle, you can barely make out little holes in some very poorly formed holes. These glands are not as well developed, and they have a greater departure from normal prostate glands, and are departure from Gleason pattern 3. So these are poorly formed glands of Gleason pattern 4. The other pattern in Gleason pattern 4 are fused glands. So again, I've drawn the lumen, the center of those basketballs when you cut these glands here in the center. So we're still making glands, but instead of an individual rounded gland that would be a sphere, we have these glands that are all fused together. So these are fused glands of Gleason pattern 4. And then the other type of pattern 4, which is probably the most important that I'll be talking about today, as it potentially impacts active surveillance, is cribiform Gleason pattern 4. And you'll notice just by looking at the slide, it bears very little resemblance to the well-formed glands of Gleason pattern 3, also very little resemblance to the poorly formed glands of Gleason pattern 4, or even the fused glands of Gleason pattern 4. And this is cribiform Gleason pattern 4. And the way to conceptualize it is to think of basically a slice of Swiss cheese. It's a solid sheet of tumor, which is what all of these cells are. This is all a sheet of tumor with basically punched out little holes in it. And I've circled some of those little punched out holes or lumina. And we'll talk about later why this is important, because it appears that cribiform prostate cancer has a worse prognosis. And again, that makes sense, given what I just showed you, that it's a greater deviation from what normal prostate glands look like. As was mentioned at the onset by some of the organizers of this meeting, and I'll just briefly mention this, there are significant problems with prostate cancer grading. I regularly review prostate cancer biopsies sent in to me by patients or clinicians, in addition to pathologists, where they've been signed out, and because the patient was a strong self-advocate, or the clinician, again, was a strong advocate for the patient, they asked for a second opinion, where there was a change of grade from maybe a Gleason 6 to a 7, which could impact active surveillance, or to a low grade, a 7 to a 6, which could also impact surveillance. Unrelated to active surveillance, but just in terms of prostate cancer in general, I would say I routinely also change other grades, could be from a 7 to all the way up to a 9 or a 10 even, or vice versa to a significantly lower grade. So as we'll talk about, correct grade is critical. And I would say probably one of the most critical aspects of a patient's diagnosis and the foundation for optimal treatment for a patient's prostate cancer. And the website for anyone who's interested is www.hopkinsconsults.org. So why is there discrepant grading? So first, let me say most pathologists are good diagnostically and grade prostate cancer accurately. But some, either due to inexperience or just a lack of skill, can be grade sometimes blatantly in error. But however, there are also some cases where grading can be subjective, and that then ends up being relying on a pathologist with extensive experience. But it's not always a straightforward process of grading. So now let me talk about criteria for selection of men for active surveillance. So some of the factors that get involved, and I talk to patients, I'm unique amongst pathologists. I talk to probably 1 or 2 patients a day where they've sent me the slides. They want my opinion in terms of treatment, discuss their pathology. And so the criteria are age based on life expectancy or the follow-up time. Patient preference. There are some patients, even though they may be good candidates for active surveillance, just cannot basically handle the potential anxiety of living with cancer, whereas others are very comfortable with that. The cancer extent based on clinical stage and imaging, and I know you've had talks, for example, on imaging and by a clinician, Dr. Carroll. And then needle biopsy findings, which is what I'll emphasize today, where it's grade, extent, and other findings. And then also based on PSA criteria, such as PSA and PSA density. So back in 1994, we were actually the first article that came out to try to come up with a prediction based on clinical and needle biopsy pathology findings to try to predict who would be a good candidate for active surveillance. And at that point, it was actually a radical concept. And we got a lot of actually flack about it because then the dogma was that basically all prostate cancer should be treated. So the preoperative model that we came up with to predict insignificant cancer in the prostate, and there were strict definitions as to what was insignificant cancer, was first that they would have a patient would have stage T1C disease, which is non-palpable disease diagnosed on needle biopsy, Gleason score of 6, and we'll talk about potentially expanding that later on in the talk, less than 3 cores involved by cancer, no core with over 50% involvement, and PSA density, where the PSA was divided by the gland weight of less than 0.15. And the importance of the last clinical PSA density is sometimes a needle biopsy could underestimate and miss more significant cancer, but a very high PSA in that cases would flag those cases as something that would need treatment. So this pre-treatment criteria accurately identified men with significant and insignificant cancer. And the most important number is this 86% negative predictive value. And what that meant was that we predicted using our criteria that a man would have insignificant prostate cancer. We were right in 86% of the time. So it's not 100%. It's better now with multiparametric MRI, but still, even with multiparametric MRI, it's not 100%. So that is something that I do discuss with patients when, in terms of the discussion of them undergoing active surveillance, in that, again, we think we have good criteria, and we'll discuss that in greater depth, but it's not 100%. Now, another thing that's important for, I think, patients to recognize, where you could have the same slide sent to 2 pathologists and potentially get totally different reports. One, we mentioned grading. There could be discrepancies in grading, but the other is even just in terms of the quantification of cancer. So again, one of the criteria for active surveillance for very low risk disease, and I'll again discuss very low risk versus low risk disease shortly, is, and our original criteria was having less than 50% of any core involved by cancer. But how you measure that less than 50%, again, could be different between pathologists because of the issue of discontinuous foci. So you could have a needle biopsy core, and this is a schematic of the red being the core, and all the red is actually benign, and these little blue circles are cancer. And there's 2 different ways that a pathologist could look at a slide with 2 little bits of cancer separated by benign tissue. They could say that overall the cancer involves 5% of the area of the core, or you could say there's small foci of cancer discontinuously involving 80% of the length of the core. We and others have been involved in studies showing that in the vast majority of cases, when you see cancer discontinuously involving the core, this represents a single larger tumor going in and out of the plane of section of the needle biopsy. So when I report a tumor with this type of a pattern, I report this as discontinuously involving 80% of the core, not 5%. But again, that same slide going off to a different pathologist might report it as 5%, and that could have a difference in terms of recommending for active surveillance. So now let me talk about the issue of low risk and very low risk criteria. So the very low risk, which has also been named the Epstein criteria, was again based on that original study in JAMA. Stage T1C, non-palpable tumor, Gleason score 6, PSA density of less than 0.15, less than 3 cores with cancer, no core with over 50%. There's also low risk criteria, which is expanded. That's basically non-palpable tumor, but it also could be T2A, which is a small palpable tumor. Same Gleason score 6 and the PSA of less than 10. The difference between low risk and very low risk is that low risk does not factor in the extent of cancer on the biopsy. You could have 10 cores with a Gleason score 6, and that would still be low risk disease, whereas that would not be very low risk disease. So why distinguish between very low risk, which again factors in the extent of cancer on biopsy, versus low risk disease? So cancer extent on biopsy and PSA density are directly associated with the risk of grade reclassification during surveillance. So when I talk about grade reclassification, that's somebody who starts, let's say, with a Gleason score 6 on active surveillance. They're followed, and on a subsequent biopsy, they have a higher grade tumor. So we don't use the term grade progression, which is often used in the literature, because grade progression implies that that 6 became a higher grade over time. It kind of de-differentiated, became worse, where in fact, most of the time when we see a higher grade tumor on a subsequent biopsy, most of the time that probably represents higher grade tumor that was present in the prostate at the time of the earlier biopsy, but that was just not sampled on that earlier biopsy. So we talk about that it's been grade reclassified rather than grade progression. So some of the studies, I'll just highlight a couple of them. So a study done at Hopkins in 2013, we showed there was a 2-fold higher risk of having at radical prostatectomy, non-organ confined cancer and Gleason pattern 4 if you had low risk versus very low risk disease. Another study looked at and found a 2-fold higher risk of having metastatic disease, prostate cancer death, and treatment failure while you're on surveillance with low risk versus very low risk. Now again, the risk of having those very adverse findings with low risk disease is still low, but still twice as high compared to very low risk disease. This is another study just to show you the difference of grade reclassification after 2 years with very low risk disease, where it's about 60% versus low, I should say about 40% chance of grade reclassification with very low risk, and then 60% at around between 5 and 10 years. So when you talk about inclusion criteria for active surveillance, it's variable, and this is confusing for patients, depends who you see. So in terms of clinical stage, again, the majority of studies include T1C, which is non-palpable, plus T2A, which is early palpable. Some include any palpable disease, T2. So this criteria that we use at Hopkins, at T1C, non-palpable, actually the minority of studies require somebody to have non-palpable tumor. Most studies use a PSA of less than 10 as the PSA criteria for active surveillance. Again, we use, some studies have used PSA of less than or equal to 15, some have used PSA of less than or equal to 20. PSA density, we have found to be a better predictor than PSA. The vast majority of times, PSA density and PSA are comparable, but there are some men who have basically very large prostates due to BPH who will have a high PSA, but a low PSA density. And those patients we have found actually are still good candidates for active surveillance because their PSA is being driven by benign tissue, not cancerous tissue. So again, most active surveillance studies do not use PSA density as a criteria. Again, we have found PSA density to be a better predictor using 0.15, and some studies use less than 0.2. Almost all studies have as the inclusion criteria Gleason score less than or equal to 6. Growingly, there are some acceptance of doing potentially active surveillance for less than or equal to 3 + 4 = 7, especially in older men, and I'll talk about that in greater detail later. Most studies have less than or equal to 2 positive cores as our initial criteria, but some use, for example, less than 1/3 of the cores being positive or less than or equal to 50% of the cores. Most use the criteria less than 50% maximum cancer per core, some less than 20% maximum cancer per core, and some, again, don't use this criteria. We have also found that unilateral versus bilateral is actually potentially a better criteria than less than 50% maximum per core. The other advantage of unilateral versus bilateral is with MRI targeted biopsies, we're seeing now more cancer per core because the biopsy is being directed right into the lesion. So this criteria of less than 50% maximum per core may not be as good of a criteria for active surveillance now in the setting of MRI, but the unilateral versus bilateral still holds to be valid. So in terms of criteria for reclassification, where on follow-up, a patient is told that they are not a good candidate for active surveillance, most studies are based on finding subsequently worse biopsies. So really the whole key for reclassification when you're undergoing a follow-up every year is really based on the biopsy more than the PSA, based on the grade, number of cores, again, the extent of cancer, and basically having worse findings than on the original inclusion criteria. So Hopkins, even though we do obviously get PSAs on everybody in active surveillance, we've never used them as the main criteria for reclassification. And no matter how we've looked at PSA, it's just never been shown to be that accurate. And there have been many other active surveillance centers that have also dropped PSA-based criteria along those same reasons. Now, where PSA can be used is in terms of PSA doubling time. So if the PSA doubling time is increasing on active surveillance, that could be something that then triggers another multiparametric MRI. It could also trigger, for example, more frequent biopsies, but typically will not trigger by itself somebody being excluded for active surveillance. What we've come up with at Hopkins is a risk prediction tool for grade reclassification in men with favorable risk on active surveillance. And so what we found was the things that were helpful to predict who's more likely to have worse disease on follow-up on active surveillance is one, if you're diagnosed before 2005. And the importance of that is after 2005, we changed the grading system. So many of the tumors that were diagnosed as Gleason score 6 before 2005 are actually not Gleason score 6, and that's why that's an adverse finding. The age of the patient, the older the age of the patient, increased risk of being reclassified. The higher the PSA density at the time of your last biopsy, also increased risk. As I mentioned, having bilateral cancer on your last biopsy is a worse finding, increased risk of having grade progression on your subsequent follow-up. As we talked about earlier, low risk disease versus very low risk is also predictive. And then the total number of biopsies not showing a Gleason greater than or equal to 7. And this makes sense. The longer you've been on active surveillance with 6s, then that's more likely that but the clinicians and the biopsy did not miss higher grade cancer, and it's more likely that's what your true cancer grade is. If you've only had 1 or 2 biopsies with a Gleason 6, there's a relatively greater risk that there may be still unsampled higher grade cancer. And then basically you've probably seen these nomograms, but just to go over them, you basically take all these variables. So you take the age, 50, you get 10 points. You take your PSA density, let's say it's 0.4, that might get you 15 points. And if you're diagnosed before 2005, you get 15 points and so forth. And then you basically add up all those points together. You get a total number of points, and that comes down and gives you your risk of having higher grade or being reclassified on a subsequent biopsy. And the practical utility that we found in this calculator is that 60% of our active surveillance cohort, and we have over like 1,300 men in active surveillance at Johns Hopkins, 60% of our cohort, we can predict has a probability of grade reclassification of less than 20% with a very low chance of us being inaccurate in that prediction. So what we can say, at least to those 60% of men, that we can reassure them that they have a high probability of successfully staying on active surveillance, and also can use that to start spacing out how frequently we do repeat biopsies. So let me talk about, I think, one of the most controversial and kind of hottest topics in active surveillance is the issue of active surveillance for men with Gleason score 3 + 4 = 7 or grade group 2. Is it safe? So at Johns Hopkins, we've not done active surveillance for Gleason score 7. We do have some men who choose it, but they're not in our formal active surveillance in terms of that's what we recommend. In contrast, you heard about Dr. Laurie Klotz up in Canada, who's also one of the pioneers in active surveillance, and he has been including some men with Gleason score 7 in their study. So if you look, again, we had no Gleason score 7s in our group of over 1,300 men. He had 13% in his group of about 1,000. There's also differences. We biopsy our patients every 1 to 2 years. They spaced it out more. But if you look at the risk of metastases, again, exceedingly low at our group where we only had Gleason score 6 men in active surveillance, 2.8% in patients in the Stony Brook group. Mortality, again, very exceedingly low at 10 years due to cancer, 0.1% versus almost 2%, and a much higher overall mortality as well. And if you look at the active surveillance for intermediate risk prostate cancer, again, in the Lori Klotz group, Gleason score of less than or equal to 6, in those patients, the 15-year metastasis-free survival was 94%. If you had a Gleason score of 3 + 4 = 7, with a PSA less than 20, the 15-year metastasis-free survival dropped to 84%. And what they concluded in that study was active surveillance for Gleason score 7 should only be offered in the setting of a clinical trial. Now, again, some things have changed since then, and we'll talk about that. So are there subgroups of favorable Gleason score 3 + 4 = 7 or grade group 2, which I'll talk about later, who would be candidates for active surveillance? Looking at the extent of cancer, the percent of Gleason pattern 4, which I'll talk about, and then cribiform versus non-cribiform Gleason pattern 4. So we did one study looking at adverse pathological findings for men electing immediate radical prostatectomy to try to say, could we define a favorable intermediate risk group, a favorable group of men with Gleason score 3 + 4 = 7, who would be candidates for active surveillance. So we looked at groups who had very low risk disease. As I mentioned, those are patients with just a small amount of cancer, low PSA, Gleason score 6. We looked at the low risk, which are Gleason score 6, low PSA, but any amount of cancer. And we compared that to the favorable intermediate risk. So that's only 1 or 2 cores of Gleason score 3 + 4 = 7 and a PSA of less than 20. So again, Gleason score 7, relatively good group in terms of at least their PSA and extent of cancer. And if we look at then these men underwent radical prostatectomy, they didn't undergo active surveillance, but it gives us a window that if these men had been on active surveillance, what their prostates would have shown and what they would have been at risk for. So if you look at the risk of having adverse pathology, and this is very adverse pathology at radical prostatectomy, patients with very low risk disease, less than 5%, low risk disease, slightly higher, close to 6%, but it jumps up dramatically to 24.7 once you had a Gleason score of 3 + 4, even with 1 to 2 cores on that biopsy. And if you look at basically even a better group, so men with, again, favorable intermediate risk, meaning 3 + 4 = 7, 1 to 2 positive cores, and no core over 50%, again, almost 20% of them had adverse pathology at radical prostatectomy. Now, what we didn't factor in, and this is something that's been relatively new that's being included in pathology reports, and I would say I've been putting this into my pathology reports for the last few years, but I would say still, I get, 40 consults a day, and I would say probably 5% of them are including percent pattern 4, so it's still not something that's caught on in general practice, but it's growing, and it should be standard of care and will be eventually. So the major genitourinary pathology societies recommend reporting the percent Gleason pattern 4 on needle biopsy with Gleason scores 3 + 4 = 7 and 4 + 3 = 7. But as I mentioned, currently it's not being performed by many pathologists. And so you could have a core, basically this is a schematic of a core with cancer, where assume all of this is cancer. So we have basically 90% pattern 3 and 10% or less than 10% pattern 4. Potentially, a patient like that with a 3 + 4 = 7 with a tiny amount of 4 could be a candidate for active surveillance. But you can also have a 3 + 4 = 7 where the 3 is close to 50%. And that patient would not be a candidate for active surveillance. It's bordering on a 4 + 3. However, if a pathologist only writes 3 + 4 = 7, and including all those studies in the past, which I just talked about, where they just talked about 3 + 4 = 7, you don't know which 3 + 4 = 7. Is it potentially a favorable 3 + 4 in terms of the extent of pattern 4 or an unfavorable? So this is still an unanswered question. So there have been some studies on this. This was a study out of Great Britain. They followed patients with active surveillance. It wasn't truly active surveillance like we know it, but nonetheless, they showed that less than 5% of Gleason pattern 4 had the same risk of cancer death as Gleason score 6. Again, the weakness is this study. It was very different treatment than compared to what we currently do. It was also an older study population where they had only 6 cores sampled, which could again be very different than what we do today when we have at least 12 core sampling. And again, I'm only going to show you a few studies just to show you the issue of percent pattern 4. This was another study out of Memorial Sloan Kettering. And this is the, again, probability of having bad pathology in your radical prostatectomy. And this line here is basically what is, if you had a Gleason score 6, this is the likelihood of you having adverse pathology. So it's slightly over 30%. And on the bottom, it says, what is your percent pattern 4, the maximum percent of Gleason pattern 4 in any core? What this basically shows is that if you have a tiny amount of Gleason pattern 4 as your worst pathology on a biopsy, it's the same as basically a Gleason score 6 on a biopsy. Once you start getting more pattern 4 in your biopsy, then the worse, you start having much more higher likelihood of having bad pathology in your prostate. Another study also looked at radical prostatectomy pathology and recurrence. And what this study showed was, again, if you're looking at the percent pattern 4 on your needle biopsy, increasing as you go from left to right. And if we just look at the blue squares for now, in terms of, again, what's the likelihood of having bad pathology in radical prostatectomy? If you have a Gleason score 6, no pattern 4, it's 11%. But in this study, as opposed to the others where they said if you had a little pattern 4, it's just the same as Gleason 6. In this study, what you can see is that if you had a little Gleason pattern 4, here it's 1 to 10%, you had twice as high risk of having bad pathology compared to Gleason 6. So again, there are conflicting studies in the literature on the significance of having a small amount of Gleason pattern 4 on your prostate biopsy as to what it means in terms of what's going on in your entire prostate. So I think we do need additional studies on percent pattern 4. And the question, is there a cutoff for percent pattern 4 that's helpful to identify men with 3 + 4 = 7 that can undergo active surveillance? Also, there are different ways to measure percent pattern 4. Most studies, and the way we usually do it, is you take the worst, basically, grade in a given case and say the maximum percent of pattern 4 on that core. But some people have looked at studies where they average all the positive, let's say Gleason score 7s together and average all the percent pattern 4s amongst all the different cores. And again, doing so, you can get totally different numbers and potentially different results. But ultimately, I think what we do need is for the patients who are currently undergoing surveillance with active surveillance with the 3 + 4 = 7, we need long-term follow-up on these men to see what happens to them. Now, I mentioned cribiform glands at the beginning of the lecture, and the importance of cribiform glands is that the vast majority of studies on prostate cancer with cribiform architecture demonstrate associations with both adverse clinical outcomes and molecular features typically seen in advanced disease. So the question is, if you have a 3 + 4 = 7 with cribiform pattern 4, as opposed to poorly formed glands or fused glands of pattern 4, should that rule out active surveillance? And basically the answer is we don't know. Again, we are reporting that routinely on our pathology reports, but I would say a very small percentage of pathologists are doing so. But again, we need long-term follow-up of men to be able to assess that. Other findings that you might see on a pathology report as they relate to active surveillance, there are some findings that do not affect active surveillance. So if you see them on your pathology report, you shouldn't just ignore them. If you see some of the parts saying atypical, or might call it atypical small acinar proliferation, in addition to having cancer, or let's say if that's the only thing you find on a biopsy, again, ignore it. If you see that there's high-grade prostatic intraepithelial neoplasia, high-grade PIN on a core, that has no bearing on active surveillance. Some pathologists get worried because they see the word high grade. They think that's bad, but in terms of this particular lesion, high grade PIN, it has no significance for active surveillance. Perineural invasion, we have shown, does not adversely affect being followed on active surveillance. But there are some factors other than just the cancer itself, the invasive cancer, that do affect active surveillance. One is intraductal cancer. Typically, it's associated with high-grade invasive cancer. So if you see it, obviously associated with invasive high-grade cancer, that rules out active surveillance. But rarely it can be a precursor lesion, an in situ cancer that has an increased risk of going on to invasive high-grade cancer. So it's different than high-grade PIN. So if there's intraductal cancer present in a case where there's tumor that is otherwise good for active surveillance, that patient should not undergo active surveillance. Intraductal cancer, you do not want to be followed on active surveillance if you have intraductal cancer. There's another entity that's very recent called atypical intraductal proliferation, or AIP. And these are cases where the glands have some but not all of the features of intraductal cancer. If it's present on a biopsy that otherwise would be, the patient would be a good candidate for active surveillance, what I would recommend is a repeat biopsy to rule out either higher grade cancer or intraductal cancer before undergoing active surveillance. What I'd like to end with is discussing the new prostate cancer grading system. So the word cancer drives overtreatment, and the fear of death from cancer likely plays some role. And if we could remove the label of cancer, that could reduce unnecessary treatment of low-grade disease. So there's been a lot of proposals to maybe rename Gleason score 6 as not cancer. We've done that actually in other organs in the body. We've done it in the thyroid. We've done it in soft tissue lesions, etc. And so, the question has come up, name it something else. Indolent lesion of epithelial origin was one name, but don't call Gleason score 6 cancer. So this has been the source of some interesting kind of controversy, and I've participated in several articles, the pro and con of calling Gleason score 6 cancer, as well as some debates at various societies. So one of the rationales for saying that Gleason score 6 should not be called cancer is that if you look and have a radical prostatectomy that's entirely Gleason score 6, no pattern 4, we have shown in this study of 14,000 men that there's no risk to having a metastasis. So a pure Gleason score 6, it can invade out of the prostate. We've shown that it can rarely even invade the seminal vesicle, but it cannot spread distantly to another site. So you could argue, if it never spreads to a different site, why do we call Gleason score 6 cancer? But the arguments in favor of calling Gleason score 6 cancer is, number one, under the microscope, it looks like cancer. It invades as I mentioned, out of the prostate. It can invade around nerves. Molecularly, it has many of the features and hallmarks of higher grade cancer. But probably from a practical standpoint, the biggest issue is sampling on biopsy. So there's a significant risk of undersampling higher grade cancer when you have a Gleason score 6 on biopsy. And even with multiparametric MRI, which has improved our sampling and identifying high-grade cancer, there's still a risk of undergrading cancer. So again, if I could have a crystal ball and some, either molecular test or the best imaging, a new imaging test, and I could look into the prostate and say, this is a pure Gleason score 6, I might be in favor of renaming Gleason score 6 on biopsy, not cancer. But the problem is, a Gleason score 6 on cancer, Gleason score 6 cancer on biopsy could be Gleason score 7, 8, even 9. That could be very high grade cancer, and I've seen that in the prostate. So my concern is that if we call Gleason score 6 not cancer, it's going to be much harder to enroll patients in active surveillance, get them to do repeat yearly or every other year biopsies if they say, I don't even have cancer. And I think many patients would be lost to follow-up, and ultimately some of those men would have a bad outcome. So I think we should call it cancer, but on the other hand, I think there's merit to that whole discussion. And what I think is, and there was a need to change what patients think when they have a Gleason score 6 cancer. So I think urologists, their job is to reassure and educate patients. But from a pathology standpoint, I think it's important that we modify how we report prostate cancer to more accurately reflect their behavior. So the problem with Gleason score 6 is the grading scale. So as I mentioned, back when Gleason did his initial grading scale, Gleason scores could range from a Gleason score of 2 if a tumor was purely a 1 + 1 = 2, all the way up to a 10. But as I said, now we don't diagnose patterns 1 and 2, we diagnose only pattern 3. So a pure pattern 3 tumor would be a 3 + 3 = 6. So the lowest grade that you should ever see in a pathology report for prostate cancer is a 6, which is totally non-intuitive. There's no grading system anywhere in the body that starts with a 6. And the problem is, for patients, if they go online and see the scale goes from 2 to 10 and they have a 6, patients are going to incorrectly think they have tumor in the middle of the grading system, which can contribute to their fear of cancer. So this was shown in a study done in looking at patients, where it was shown that the majority of patients, 84%, agreed it would be clearer to them if grades were reported on a scale of 1 to 5 instead of 6 to 10. 88% would prefer they have a grade group 1 or a group 1 cancer versus Gleason 6. And 80% would feel more comfortable choosing active surveillance if they were told they had a grade 1 or group 1 cancer versus a 6, even if ultimately they were told 6 is as low as you get. So it's a perception issue. The other problem with the Gleason system is Gleason score 7 is not homogeneous. 4 + 3 = 7, where there's more pattern 4 than 3, has a much worse prognosis than 3 + 4. So it's confusing for patients, again, just with the words, if you just think of 7. So basically in 2013, myself and colleagues at Johns Hopkins came up with a new group grading system for prostate cancer, where we classified prostate cancer into 5 groups, 5 grade groups, 1 through 5. 1 less than or equal to 6, 2, 3 + 4 = 7, and then the higher grades listed. And the first grade groups 1 and 2 are the critical ones for active surveillance. But this just shows you the risk of cancer-free progression after radical prostatectomy, showing virtually you cure everybody with a grade group 1, even those that go out of the prostate, even those with a positive margin. Grade group 2 still has an excellent prognosis. And then once you go to a 4 + 3, which is grade group 3, the prognosis drops significantly, and then worse for 4 and 5. And this new grading system is now accepted by the World Health Organization, College of American Pathologists, the AJCC, and virtually all other societies, and it's being used broadly. So in summary, I've talked about the critical role that pathology plays in criteria for selection for active surveillance, for intervention on active surveillance, and reporting prostate cancer to more accurately reflect extent and grade for both urologists and patients. And with that, I'll stop and look forward to hearing your questions.
Well, I guess I can take it from here unless Joe has a message.
You could make a comment real quick if you like, Howard.
Do what you got to do, because I got to get to the questions.
Okay. Well, what I would like to do at this point is that we have a couple of quick polls that we'd like to execute. And if everyone would just pay attention to your screen for a moment. And when I put the poll up, I'll read it for those who are on the phone, and it'll probably be up for less than a minute. So please respond as quickly as you can. The poll says, have you ever gotten a second opinion on your biopsy slides? Okay, and the responses are yes, no, or didn't know I could. Okay, it looks like we've gotten pretty much all the responses. There's no more being added. And the results on that one were the 5% said I didn't know, and we had 50-some% that said yes, and 40-some% that said no. 54 and 42. Okay, and here's the second one for you. It said, if you're on active surveillance, did you have a 1-year confirmatory biopsy? And again, the options are yes and no. Okay, it looks like everyone that might have wanted to chime in has. And so the responses we got there, we have actually, it came out 50-50. 50%
Like
said
everything
yes.
else in America, you know.
Yep, there you go. Okay, well, thank you very much for that. And now, Howard and team, if you would like to shower the good doctor with your questions, that would be appreciated. Thank you.
Okay, I think I'll start off. And one thing is sort of a housekeeping question. We had several people asking where they should send slides to. So, Dr. Epstein, is there a website that you can
Yeah,
just...
so the website is www.hopkins, Hopkins, consults, consults, one word, hopkinsconsults.org.
So are we back here now? Okay, and then another housekeeping question like that. Is there an age limit on the slides that you can accept?
Nope, absolutely not. I mean, literally, we have slides at Hopkins back to the 1930s. So slides are kept, and they can always be looked at no matter how many years they are ago they are.
Well, that's a long time on active surveillance, isn't it?
Totally.
But at any rate, in terms of second opinions, when should men seek a second opinion? When should the alarm bells go off?
Yeah, so again, if we're me, if my family member or friend, I would say anytime you have any pathology, and we're talking about prostate cancer, but if it was breast, lung, anything, I would have a second opinion by an expert. Even if it's pathology done at what you think is a top-notch place, you never know who's reading those slides. It could be somebody who's not necessarily top-notch at that good place. And again, literally today I saw an egregious error by somebody in a top-notch place that, if you just went by the reputation of the place, you would say, I don't need a second opinion. So pathology can be subjective. And again, most pathologists are good. I want to emphasize that. But there are some pathologists who, for whatever reason, are not so good. They either due to inexperience or just their skill set. And again, your pathology will drive everything going forward. And it's insurance pays for it that almost all the time. It's I think $200 and something. Even if you had to pay out of pocket, if that's going to determine your whole therapy, to me, that's a small price to pay to making sure that you're getting the right treatment based on the right diagnosis.
Of the second opinions that you render, what percentage end up with a higher score and what percentage end up with a lower score?
Yeah, so overall, I'd probably say I change the grade about close to 20% of the time in the cases that are sent to me. And it's variable up and down. Certain grades are consistent at the high end. Pathologists almost never diagnose very high grade cancer. They're just afraid to diagnose the highest grade cancer. And we've done several studies to show that. But even at the low end of 6 versus 7, it's variable. It can be overgraded, undergraded. Both situations occur significantly.
I just have one more question along these lines, and then maybe one of my colleagues can dive in. But you've tested yourself, haven't you? Haven't you looked at slides that you know,
You're breaking up. I can't hear you.
Howard, break it up. Let's shift it over. Elliott, you want to pick up for a moment while Howard gets together?
Yeah, I thought I knew what he was going to ask, but I'll wait for him to come back. So Dr. Epstein, we had a lot of questions about for 3+, those of us in the 3+4 category. One was, what is the difference between 3+4 and 4+3? Is it simply the percentage of 4?
Right. So literally, so again, assume a core is like a thread, and on that thread, let's pretend just keep it simple. Pretend the core is like 1 inch long, that thread, and let's say it's all cancer. So you have 1 inch of cancer, and and you have a mixture of patterns 3 and patterns 4. If you have 60% pattern 4, so 6/10 of that inch is pattern 4, and 4/10 of that inch is pattern 3, then that's a 4+3. On the other hand, if you have more 3 than 4 in that core, then it's a 3+4. But again, it's a broad range. It's a sliding scale. So the 3+4 and 4+3 just looks at 50%, over 50% pattern 3 versus under percent. But you can have a 3+4 with 1% pattern 4, up to close to 50% pattern 4, and you can have a 4+3 with like 60% pattern 4, or a 4+3 that's 90% pattern 4, that's almost the same as a 4+4. So that's why we're now reporting percent pattern 4, because it gives much more detailed information to clinicians other than just 3+4, 4+3. So 3+4 for men with a small amount of pattern 4, and people often use 10% pattern 4 as a cutoff, maybe 15% pattern 4, may be a good candidate for active surveillance. But once you start getting 30, 40, 50% pattern 4, I should say, then you're saying you're getting too much for it to be probably a good candidate for active surveillance.
Okay, thank you. That was exactly what I think a bunch of us wanted to know. The other thing, there was another sort of related question from the audience about how does age factor with 3+4? I guess that meaning in terms of choosing active surveillance. If there was, let's say, a small amount of 4 and you were thinking that they were a good candidate for active surveillance.
Yeah, so the way that age factors into things, and it's maybe not as age as much as life expectancy. I mean, somebody could be, a 70-year-old who's, their parents lived to, 90-something years old, and they're perfectly fit and run marathons. And you could have somebody who's 50 who's, had bypass surgery, et cetera. So age is one thing, but probably life expectancy, when we're talking about age, that's what we're really getting into, is life expectancy. So the longer you're going to be on active surveillance, and it's a horrible dilemma, because I talk to, again, a lot of patients. So the biggest dilemma for active surveillance is a young man. Take somebody in their 50s. So the problem is treatment for prostate cancer has morbidity, impotence, incontinence, the main ones. And in somebody in their 50s, those morbidities have potentially a greater impact than, let's say, somebody who's, let's say, take the extreme, it's 70 or 80. But on the other hand, being followed for active surveillance from age 50 for 20 or 30 years, allows that cancer to grow 20 and 30 years. And we know cancers do grow, even slow growing prostate cancer. So the problem with the 3+4, if you're older, and let's say you have less than a 10-year life expectancy, then you would say more likely I'm going to die of something else than I'm going to die of my 3+4. But a younger man who's going to be around for 30 years, let's take the other extreme, that being followed with the 3+4 is riskier, because there's a greater chance that that 4 will grow over time and become more of a problem. But those are the extremes, and obviously in men somewhere in between, then that's kind of the issue of how to deal with it. So that's why I think I think we have to look at more than just 3+4. We have to look at how much pattern 4. We have to look if it's cribiform or not. There are also molecular tests, which you've heard about, that can be, again, potentially a factor in. look at the multiparametric MRI. Is there a big lesion there, or is it, again, kind of, they don't see anything? You know, use the risk calculator to say if you've had multiple, if you've been followed for a long time, again, with a bunch of 6s, that's still favorable. It means you probably have a small tumor. So I think it's an individualized decision, but I would say once you have a 3+4, there's definitely increased risk. And you have to balance that increased risk with the side effects of treatment. And again, try to use all the information that you have available to try to make an informed decision.
Thank you for that. Howard, did you want to pick up on that question that you were in the middle of asking?
For technical difficulties, I have a different question, but I defer to Alexa if she has a question.
Dr. Epstein, I just want to say your presentation was amazing, and we're receiving so many comments in the question section about how wonderful it was and how informative. And I want to do a quick plug from the last question that was answered. Here at ANCAN, we actually do have a virtual support group for men under 60 with prostate cancer. So if that's something you'd like to know more about or be in that community, please check that out. It's a great resource. So we have this excellent question that came from someone in the audience. Regarding the percent of 4, is this the percent of core or the percent of the tumor in core?
Yeah, so that's a good question. It's basically the percent of the tumor. So we only look at the tumor when we're doing percent pattern 4 and saying of the tumor that we see, how much is 4 and how much is 3. And again, 10% seems to be the cutoff as being potentially a favorable amount of pattern 4.
Dr. Epstein, you also mentioned, you were talking, one of the factors in your presentation was about intraductal carcinoma. And we had a question from the audience saying, what is intraductal carcinoma?
Yeah, so it's a relatively newly described entity in the prostate. And intraductal cancer is basically cancer that hasn't invaded yet. So it's not creeping all over the prostate. It's confined to pre-existing benign prostate glands. So basically in every organ that we have cancer, we have something called in situ cancer, where it means the cancer hasn't broken out to start spreading, where it can get into blood supply. And if your whole cancer is in situ cancer, you're cured. It can't spread anywhere. Now, there is this entity of intraductal, which is the same as, in a sense, in situ cancer of the prostate. If all you had was in situ cancer, and I've seen some rarely prostates come out, all we have is intraductal cancer, that patient's 100% cured because it's never spread outside the confines of pre-existing benign prostate glands to get access to blood supply or to do any harm. But typically when we see that intraductal cancer, usually it's associated with high-grade cancer, bad cancer, such that on a biopsy, if you have, let's say, are being followed for active surveillance, or let's say you have a Gleason 6 plus this intraductal cancer, that's a red flag warning that this is not just a good 6, that you have something else hiding in your prostate, more likely that's higher grade invasive cancer somewhere that needs to be treated.
Thank you. I had some other questions here. One had to do with capsular involvement. What does that mean?
Yeah, so when we talk about capsular involvement, we talk about basically, is the prostate cancer in your whole prostate confined to the prostate, or has it spread out of the prostate, beyond the edge of the prostate? So from an active surveillance standpoint, the importance of that is all the studies that I talked about where, so in the ideal world, if we're trying to predict who's a good candidate for active surveillance, we would look at a certain finding, let's say cribiform glands, or maybe how much percent pattern 4, take 500 men, follow them for 10 years. That's the ideal study that we'd want to do, to say what happens to those men. The problem is that takes 10 years. So for example, we're just learning about cribiform glands now. We're just starting to report percent pattern 4. So we don't have 10 years of follow-up of men on active surveillance with those findings to say, could they still be potentially candidates, or who is a good candidate, for example, with Gleason score 7, on active surveillance with some of these features or without some of these features. So what we use as a surrogate for that is basically men who might be candidates for active surveillance, but undergo radical prostatectomy. So we know what's in the prostate, and if it's something bad in the prostate, then we can say, you know, that person, if they hadn't had their prostate out, would not have been a good candidate. And so we kind of work backwards. So one of the criteria when I talk about trying to predict who's a good candidate for active surveillance, those studies talk about adverse pathology in the radical. If you have it, that's not a good candidate. One of those criteria for adverse pathology was, did the tumor go out of the prostate? Because you wouldn't want to be following somebody who has tumor out of the prostate, because that could grow and grow and grow. And eventually, if they need treatment, then they're probably not going to be able to be successfully treated. But on a needle biopsy, with rare exception, we cannot tell. People ask me this all the time. People ask me to stage the needle biopsy because they look up clinical staging like organ confined, not organ confined, T2, T3. You cannot stage prostate cancer on a needle biopsy because we don't have the whole prostate. We're just getting a sliver, a tiny sliver of it. Literally each prostate needle biopsy samples 1/10,000th of the prostate gland. And that's why this sampling artifact is such a big problem. Rarely we see tumor going out of the prostate on the needle biopsy. Those tend to be horrible high-grade cancers, not the kind of cancers that we see for active surveillance.
Can I dive in?
Yeah, go ahead, Howard. Yeah.
I'm sorry. We've been hearing a lot from urologists about transperineal versus transrectal biopsies. And I wonder, from a point of view of a pathologist, does it matter how these biopsies are conducted?
Yes, that's a good question. Literally, so historically in the United States, and I would say even now, probably 95% of the biopsies are done transrectally. And so you're going to get biopsies from left and right, apex, mid, and base, the apex being towards the penis, base towards the bladder. But some people are doing them transperineally through the skin. And for example, I got one today like that. And basically the needle biopsy goes basically from the penis all the way up towards the bladder, you know, on kind of the posterior part of the prostate, the middle part, and the anterior part. So under the microscope, they look the same. The difference is, and the potential advantage of the transperineal biopsy is to sample anterior tumors. So basically the ones that are going through the rectum are sampling the back of the prostate, the posterior part of the prostate, where 75% of tumors are, but 85 probably more likely. But 15% of the time, there's a tumor anteriorly, basically away from the rectum. So a transrectal biopsy may not hit or sample well that anterior biopsy because it's away from the rectum. And cancers can be missed or undersampled. A transperineal biopsy, you can direct it into that anterior part of the prostate and sample it. So I would say most places are still doing transrectal biopsy, but if multiparametric MRI shows, for example, an anterior lesion, that might be a lesion that would be better sampled transperineally, for example. But the issue is, and it becomes one of the, I would say, great parts of dealing with prostate cancer as a pathologist or a clinician, but also a maddening part for both patients and pathologists and people who deal with the disease, is that we rapidly change. We have, you know, a few years ago, we didn't have multiparametric MRI. Biopsies are being done differently now. So all the criteria that I talked to about active surveillance, for example, in terms of less than 50% cancer in a given core, 1 or 2 positive cores, that was based on transrectal biopsies. So in a transperineal biopsy, you can't necessarily apply those same criteria. So once you start doing anything different, you can't take studies that were done in the past and say that they would be valid for this new technique. So that's the disadvantage of the transperineal. You sometimes maybe don't know what to do with that information. But there are some advantages, again, from if it's an anterior tumor, that may be a good way to go.
You know, you mentioned the MRI for targeted biopsy. Is there a value in a random biopsy?
Absolutely. So there initially, like this happens with every new technique. When ultrasound of the prostate first came out many years ago, they said, you don't even need the biopsy. The ultrasound can do everything. And then subsequently studies were shown, ultrasound really wasn't that good. Same thing with multiparametric MRI. The initial study saying this is, God's greatest gift, prostate cancer. You don't need a biopsy. And what we've shown is it is an improvement. It's a significant improvement. But nonetheless, sometimes you will find the worst cancer in the non-targeted area, not the MRI lesion, when you do the standard plus the MRI. Most of the time, the MRI will find the highest grade lesion, but not. And so that what's recommended is, yes, do the targeted lesion, but still do the standard sampling throughout the prostate, because MRI by itself can still miss the worst tumor.
Dr. Epstein, I actually have a question from the audience that sort of falls into this theme, and I'm curious myself. Has the increased use of MRI-guided biopsies increased the diagnosis of prostate cancer?
Yeah, so the good thing about multiparametric MRI is one finds the highest grade cancer. And if anything, it sometimes misses the lower grade cancers. It doesn't see it on the MRI. So in a sense, if the goal is to treat only significant prostate cancers and potentially not even find some of these very low grade cancers, that's an advantage of the multiparametric MRI. So it's not necessarily increasing cancers detected overall, it's increasing finding what we think are the more significant cancers.
I'm not sure if you answered this at the very beginning, but we've had a lot of questions about what percentage of, when you do second opinions, what percentage of those actually upgrade or downgrade?
Yeah, overall about 20%, I would say, go either way, upgrade or downgrade. So, okay. But again, you can't predict, whether it's from a commercial lab versus a community hospital versus an academic center. It's, so the difference is, patients can choose their surgeon, and I recommend surgeons to patients, and I recommend, somebody having at least done 1,000 robotic radical prostatectomies if you're going to undergo surgery. So you can choose your surgeon. Most people can't choose where their specimen is being sent to initially, the pathology, and you don't know who that pathologist is. You don't know their skill set. So it's a random thing. They could be good, they could be not good, and you have just no way of knowing unless you get a second opinion from someone who you do trust.
If I may ask, can biopsies cause erectile problems or other side effects?
Yeah, it is a problem. I mean, so with transrectal biopsies, there are issues with sepsis, and so patients do get antibiotics, and they get antibiotics in forms of an enema. And if you have too many biopsies, there are potentially issues with impotence. So there, it's, again, the whole issue with the young man on active surveillance, what we're trying to do initially, again, when we came up with criteria for active surveillance, as I mentioned initially, it was a radical concept, and people were saying, patients are going to die, you should not be doing active surveillance. So we came up with very, very, very stringent criteria to choose the best of the best patients to go under active surveillance, and they did well. And once that happened, then we can start, in a sense, relaxing the criteria to include more men undergoing active surveillance, and that's the ultimate goal. But one of the goals also is to try to stretch out how these biopsies are done. So initially, we might do biopsies every year, but we try to stretch them out to every 2 years or maybe every 3 years, depending on their findings, depending how long they've been on active surveillance, because there is a limit to how many biopsies you can do. They do cause scarring also. So if you have so many biopsies and eventually you do need treatment, let's say you eventually 7 years down the road, you decided, you had worse disease, and you wanted a radical prostatectomy, you might not be able to because you'd have so much scarring there from all the biopsies. So ultimately, we're trying to find ways to decrease the number of biopsies as much as possible. But still, again, you can't cut them out because that's the only way you're going to find if there is worse disease there.
How many biopsies are too many biopsies?
I don't think anyone knows.
Then, if I can stay on this train of thought, Peter Carroll, in our first session like this, said he wanted to get out of the biopsy business. Do you think that's possible or wise? And where do we stand in terms of liquid biopsies?
Yeah, I don't see that happening anytime soon. Most of the liquid biopsies, which means basically you're looking for something in the blood for the most part, that's usually for more advanced disease, where you might find circulating tumor cells that you might be able to predict who has, advanced disease. But for this prostate cancer group that we're looking at in active surveillance where it's early, there's probably unlikely to be found something in the blood that we're going to be able to supplant a physical biopsy. There are molecular tests, but again, the molecular tests are based on the biopsy. And even those, you had a whole talk on that, so I won't go into that. But I'm not sure there's really great data on those molecular tests with active surveillance and patients who are being followed. So I think that's an open area as well.
We have had several questions from the audience about genomic tests. So, and one of the things I wanted to ask you was how does that affect your sense of how active surveillance works? But also, it seems like there could be cases where a genomic test could be favorable, but the biopsy report might be a little bit, might show something different, like Cribiform or something like that.
Yeah, so the major problem with the molecular test on active surveillance, and it's not a fault, it's just a limitation, what I mentioned before, that we just, it's a relatively new test, these molecular tests, and consequently, we do not have data on, for, like I mentioned before, 500 men, with these molecular tests being followed on active surveillance for 10 years to say, do they add anything or are they potentially misleading? What the molecular tests do is, again, look at surrogates, looking at what's going on in the radical prostatectomy and hypothesizing if these men had been on active surveillance, what, would that have been good or bad? But again, not following directly doing them on active surveillance patients. And there's conflicting data. So what the holy grail of the molecular test would be that if you have a Gleason score 6 or Gleason score 7, it could tell a bad 6 versus a good 6 and a good 7 versus a bad 7. And again, I'd say there's conflicting data on that, depending on the studies, whether they can do that. The issue is sampling. So, and to me, that's the bigger problem that molecular can't handle, because if you just miss a higher grade component, I don't think the data is very strong that the molecular test, let's say if you have a 6, but there's, bad high grade cancer somewhere else in your prostate that was missed, I don't think there's good data to show that a molecular test on that 6 that was sampled can tell you that there's a high-grade cancer somewhere else. And that's why I think ultimately we still need biopsies. Where again, multiparametric MRI has been, I think, a major leap to finding those higher-grade cancers. So it's a step in the right direction. The molecular test, I'm not as sure is giving us that answer yet. At least I don't think the data's there.
Dr. Epstein, one of the things I'm so curious about, because we are talking about futuristic things like liquid biopsies and, of course, genomic testing and other things like that. I would love, and our audience would love as well, for you to talk about artificial intelligence and pathology and where you see that headed, or if it's headed there at all.
Sure. So I've been involved in it. A lot of people have starting to get involved in it. Probably the biggest role that the most groups are working on in active surveillance is doing grading by computer. And the way they do that is they'll take 1,000 cases graded by supposedly an expert, and then basically have the computer analyze that and come up with how to grade based on a computer. And what I would say is we're not there yet. Number one, in that it can do it pretty well, but the problem with pathology is there's a lot of artifacts in pathology. Slides are not, it's not something like a rat in a study where all the rats are exactly the same. Everybody's stains look different. If I look at, I get material from labs all across the country, and different labs, it looks different. Some of the histology is bad. You have tissue from other organs that gets sometimes on a prostate biopsy, and sometimes you have other tumors involved in the prostate that aren't even prostate cancer. And how's a computer going to handle that? Because it's never been taught how to handle that. So it's something where it may come into use down the road. From a commercial standpoint, I'm not sure how it's also going to be used, in the sense that, you know, for example, somebody in a laboratory, would they spend $10,000 on a software program and they have to spend $100,000 to get the machine to scan the slides when they could send it to me and insurance pays for it, so it's free to them? So from an economic model, I'm not sure, even if it ends up being potentially valid, whether it'll take off. But it's interesting, and you know, it's something that you know, could be used more in the future, but currently it's a research tool.
Dr. Epstein, this is Joe. Just a quick interjection here. We had talked before that you said that you'd be willing to go a little bit overtime if things went out that well. We have over 300 people who are still pelting us with lots of questions. So if you'd
Sure,
be willing to hang out for a little bit longer.
Sure, no problem.
I think, you know, we're getting lots of good feedback from what you're providing, and you know, I think it's extremely valuable. So thanks.
No problem at all.
Dr. Epstein, we had a couple of questions about like what actually the mechanics are. Like, do they send all of the slides to you from, or just what do you need to see? And also about the original report. Like, are you reading the original report before you do your analysis? Does it influence? You know, is there an influence there? Do you wait to look at it till afterwards? Like,
right. So I would say in general, I'd probably recommend patients sending all the slides, because sometimes we will find something that was totally missed by the outside pathologist, that if they had not sent all of them, you know, we wouldn't have identified that. So we always need the pathology report. I would say it does not influence me. The reason why we need the pathology report is, number one, to make sure I'm looking at the right patient slides. We match slides. One of the critical things, you know, match the slide number with the patient's name and make sure everything, you know, that you're looking at is, there hasn't been a switch off. They didn't send you the wrong slides. I also look at it from this, that again, it doesn't influence what my diagnosis is, but it influences sometimes how I report the case, just from an educational standpoint. So if they call it something and I call it differently, I'll explain in my report why, for example, there may be a difference for an educational standpoint to the outside pathologist. So from that standpoint, yeah, we always have the report, but ultimately it's going to be what I think, not obviously what was written on the report.
thank you for that.
Sure.
Yeah, I'd like to follow up on something that was mentioned earlier. One of the people in the audience, actually, let me read what he said. He said, I would probably have had radical prostatectomy were it not for Dr. Epstein, exclamation mark. Any rate, well, this leads into, there's another part of this. He says, now that men have been on active surveillance for a decade or more, are there studies on remission or regression of low-risk prostate cancer? That's
a good question. So there are certain organ systems where we do definitely see cancers basically regress. They just die out. In the testis, in the urological system, the testis is a common site where, you know, tumors can just totally scar down into nothing. Prostate cancer is not one of those organs. So if you are diagnosed with prostate cancer, you have cancer in your prostate. Now, again, that could sit there doing nothing for decades, but it's not disappearing. So I talk to patients who say, you know, I had a cancer on my biopsy. The second biopsy showed no cancer. Did the cancer go away? And the answer is no, the cancer didn't go away, but that's a good finding. And that's one of the findings that we've shown is a good finding to being able to stay on active surveillance. It means your cancer is small, and it means that the second biopsy missed it. And again, the prostate sample the needle samples such a tiny area. If you have a small cancer, very likely it could just miss the cancer. But again, it's not going away.
You know, we know that in the COVID crisis, a lot of men have postponed routine PSA tests and so on, and routine office visits. But here we have a question: is it safe to take the coronavirus shots if you're on active surveillance, or other prostate cancer for that matter?
Yeah, I think in terms of any vaccines, there's no risk in terms of taking it if you have cancer. So definitely I would recommend people taking it. I mean, scheduled to get mine in 2 days from now, and I'm looking forward to it. I think everybody, if they have the availability, should get a vaccine, absolutely. But in terms of the risk of delay, there definitely is a risk. I've seen sometimes where somebody missed a PSA check. They should have had it, they were scheduled every year, and instead they had it 2 years, 2.5 years. And in that interval, it jumped, significantly, and, the cancer had increased during that time. So there's a potential, even though most of the time it doesn't happen, with prostate cancer, that if you lengthen out too much your interval checks, you may miss a rise in PSA.
You hinted at this earlier, but a physician in the audience asks, what percentage of the prostate by volume is sampled with 12 cores?
Yeah, so so it's basically, 10 out of 10 thousandths of the prostate, 1/1000th of the prostate. Very tiny amount. So the scary thing, I'll just say, so the scary thing, and I've seen, it's uncommon, but I wouldn't say it's rare. I mean, I've seen cases where, all the cores are benign, and then you have one core with a small amount of Gleason 10, or, a bunch of Gleason 6, and one core has high-grade cancer. So if that one core didn't sample that high-grade cancer, somebody would have, thought they had either no cancer maybe or good cancer. And again, that's the importance of the routine biopsies, not again to look for progression, but to look for sampling in terms of identifying potentially cancer that was missed. One issue that comes up is in terms of saturation biopsy. So typically you get 12 to 14 cores. Let's say now 12 and maybe a targeted lesion, 14, 15 cores. There's also something called a saturation biopsy, where literally you try to biopsy almost the entire prostate. With it's obviously you're not doing so, but you're doing 24 cores, maybe 30 cores. I used to think that would be, if I was diagnosed with prostate cancer and going on active surveillance, I would have a saturation biopsy to try to make sure I don't have a higher grade cancer. I think now with the MRI, the multiparametric MRI, I think maybe saturation biopsy isn't as critical as it once was, but it's an option also.
Yeah, Ken Mason, did you have a question? Ken?
Yes, I've noticed that many of the listeners have been posting questions about genomic and generic, not generic,
Genetic.
help me out, Doc. Yeah, tests and what the, not the purpose, but how those could figure into their diagnosis. How would you talk about that a little bit?
Yes, I mentioned it a little bit before. If I was on active surveillance, let's say I had a Gleason 6, or even a 3 + 4 = 7, I typically probably wouldn't myself be getting genomic studies on that to try to determine my course of treatment. The one study that we are doing at Hopkins, if you have a Gleason 6, we're doing something on the slides called P10, PTEN, to look for loss of it. That's associated with a potentially more aggressive tumor. Again, it's a small percentage of men who have a Gleason 6 who lose P10, but potentially with a loss of P10 and the Gleason score 6, again, you might reconsider active surveillance, or at least consider getting a repeat biopsy. But even that's definitely not something that I would say is standard of care.
Okay, if I may sneak in one other question, piggyback on this. I feel like I'm in Washington, D.C., appearing in front of Congress, but I know I'm not. You had written an article. You had written an article in PCRI in 2016, and it resonated for me because you spoke of not rushing to treatment. And you also noted the importance of having a second opinion on a biopsy. It's been less than 5 years, but do you still believe the same? Has anything changed?
Yeah, so one thing I do tell men, which I think is good news, I mean, if they have low risk or very low risk disease on their biopsy, or even a 3 + 4 = 7 on their biopsy with, let's say, a low percentage of pattern 4, it isn't something that you have to rush to make a decision in terms of your treatment or no treatment. It's something you can take months to figure out and talk to different individuals. You know, just like in terms of if you decide treatment, there's so many different types of treatment. It used to be that there was only 2 types of treatment for prostate cancer. Now there's a multitude. And it's important to talk to, not rush to make a decision, and to talk to various experts in all those disciplines to decide what might be best for you. But again, there shouldn't be a panic mode if you have low risk or very low risk disease, or even favorable intermediate risk disease, in terms of making that decision.
Thank you very much. Is there a particular question that when men call you up to ask you about their biopsy and the pathology report, what is the most common question that you receive from these men?
Yeah, so most men will ask me, so again, I get a broad spectrum. I get the worst cancers and the best cancers, but in terms of this talk, let's talk about the best cancers. So the biggest question they'll ask me, am I a candidate for active surveillance? And the first question I ask them before I even discuss the pathology is, you know, what are your thoughts? You know, are you comfortable being followed if you had cancer? If you have cancer, are you comfortable knowing you have cancer, you know, being followed for years carefully? Or is it something that literally, and I've talked to men where they say every day they wake up and they say, you know, I think I have this cancer growing inside me and it's, you know, it's ruining my life. And so if you're even thinking of active surveillance, you have to be able to almost put it out of your mind. And that's what I talk to many patients, where they just put it out of the mind almost until they're ready for, you know, 1 year down the road where they're getting their repeat biopsy. And, then they may be anxious to find out the results of the repeat biopsy, but at least during that year, they've had a good quality of life where it hasn't been this sword hanging over their head. So that's the first thing. And then the other thing is their kind of risk level, because again, it's not 100%. So there are some men who, for example, could be impotent, where they say potency is not an important thing for me, and therefore treatment is something that's not as adverse as somebody where potency is very important in their life, for example. So it's a very individual decision. And then I describe the pathology and I tell them whether I think they're a good candidate or kind of where they are in the spectrum. You can be a very good candidate, a good candidate, a not so good candidate. And there are some people who I'd say, I think you're not if you were me, I wouldn't be a candidate for active surveillance.
Okay.
Thank you.
Can I dive in? We're looking for your comment on active surveillance for African-American men. One of the members of the audience said it's been said that Black men tend to have more aggressive cancer. So, you know, is there any reason to believe that Black men maybe are being steered away from active surveillance?
Yeah, so it's a tricky issue. First of all, there haven't been as many studies on African-American men, let's say on active surveillance compared to Caucasians, for example. And so it's a weakness. I mean, so you just don't have the data to some extent. When we looked at our data, we found that our criteria for predicting who's likely to have insignificant cancer, meaning who would be a good candidate for active surveillance, our criteria were not as good in African-American men compared to Caucasians. And the reason was, turns out that African-American men, their cancers tend to be more in the anterior part of the prostate relatively, meaning that cancers are away from the rectum and they're just harder to biopsy. So there's a greater chance that they may not be sampled as well compared to cancers in Caucasians. And that's, again, an overall, it's not for an individual man, but just overall. So on one hand, cancers in African-American men are more aggressive. We think that's true. Not to say there aren't good low-grade indolent cancers in African-American. Obviously, they do exist in that population. But overall, African-American cancers are more aggressive, and the active surveillance criteria don't work as well in that population. So the answer is yes, African-American men should be considered for active surveillance. I would definitely say if I were African-American men, I would definitely, with prostate cancer, I'd make sure I had a multiparametric MRI, because that's just kind of a study that would detect, for example, the anterior tumors that you would miss on other imaging and on biopsy, just routine biopsies. So that would be a key thing that I would put in there as a recommendation.
Then
But I guess
somebody else asked.
let me just add one other thing about active surveillance, which I think is important. So if you're undergoing active surveillance, I think it's critical to be ideally in a formal active surveillance program where you're in a center where they're following large men with active surveillance. They'll be the one who will know the latest data. They'll have the latest equipment, the latest test to be able to use, as opposed to just potentially by your private urologist only, because it's not a routine thing, and I think a lot can be learned. The studies that do it and follow men in active surveillance for long periods of time have a lot of information that they've learned from following men. But in terms of the repeat biopsies, in terms of the MRI, serological tests, etc.
Now, somebody else asks, how much would 5 years of active surveillance cost? In parentheses, he says, just including the cost of doing 3 biopsies and having pathologists read them. So
yes, I don't know the costs, but what I would say is they have a point in that active surveillance ultimately is more expensive than for example, a radical prostatectomy, which is a one-time thing. What I would also add with active surveillance that I think is important to recognize is that maybe a third of men on active surveillance eventually have treatment because they have worse disease on their biopsies, but that could be several years, multiple years down the road. And what I would argue is that that's several years down the road of higher quality of life. And so even if ultimately some men with active surveillance undergo treatment, that shouldn't be a negative about active surveillance. Again, I think they still received a good benefit from that. Or they may, by the time their disease looks a little worse, they may be older and have a higher, morbidity, where maybe again the treatment won't be as aggressive than had they got the treatment, years earlier.
Dr. Epstein, we've had a number of questions from the audience. I think you may have mentioned it, but just about how much it costs to get a second opinion. Do you personally do all the readings, or do you have colleagues that read it?
I read every case that is sent to me, with exception when I'm out lecturing someplace, which obviously last year it didn't happen. So I've been at the hospital pretty much, all the time. When I'm away, I have another colleague who's an expert who reads them. But what I tell patients who call me is, I'm never gone that long. I might be gone the most a week. So I tell them just if they want me to look at it, just tell them to hold it for me, and I'll look at it when I come back. Or if somebody else has read it because I was away for a week, they can definitely just call us up and tell me to look at it, and I'll look at it again, and I'll make sure I'll analyze it and put in there that either I agree or disagree with what initially was read.
And the other follow-up was about having a consultation with you, and is that something that you would do? And
yeah, so I talk to patients. It doesn't have to be a formal consultation. I talk to them on the phone. I don't charge for any time I talk on the phone. But what I do require is I have to see the pathology before I talk to them on the phone, because they could have something, let's say they could be having a Gleason 6 on their biopsy and they want me to talk to them, but I could look at their biopsy and it's not a 6, it's a 7, and the whole conversation would be different. So I have to look at the pathology, and then I'm glad to talk to patients about it on the phone. And again, there's no charge for talking to people, obviously.
Thank you.
Well, don't be surprised if you get 300 phone calls tomorrow, so be prepared.
Tomorrow's a busy day, so maybe wait till next week.
Okay. Let's see here. Oh, somebody was asking whether it was true that the peripheral zone has 95% of the cancers.
Yeah, so the peripheral zone, which is mainly the posterior part of the prostate, has about 85% of the cancers. But 15% are these tumors that are away from the rectum, very anterior, that prior to MRI, we just didn't detect them well at all. Now we're starting to pick them up better.
And
I
then,
actually have a question that's kind of in the similar vein. All urologists cannot be accurate in collecting biopsy samples. How do you, as the pathologist, know how accurate they will be?
Yeah, so that's a tricky thing. We get a variety of, there's a variability in the how good the cores that are sampled. Sometimes we get nice long cores and we know they've done a really good job of sampling it. Sometimes the cores are small and fragmented for whatever reason, and it's not a great sample. So again, that's just another reason to typically get a biopsy from a place where at least they deal a lot with prostate cancer, where they just have, so there's a skill in terms of biopsying as well. So you just want to go to somebody who's experienced, who's had a lot of practice doing so.
Dr. Epstein, how are we doing with time? Are you still okay?
Yeah, maybe another 5 minutes or so.
Okay, great. Thank you.
We actually did have several questions about the angle of the biopsy needle, I guess. They were talking about the angle of the cut, but can that, when this particular question said, can a gland look like it's fused because of the angle?
Yeah, I see what they're saying, right? So that's an excellent question. It's a very technical question, almost like a pathologist would ask that question. So I give credit to whoever asked that question. So that's a whole issue of poorly formed glands of pattern 4 versus well-formed glands of pattern 3. The problem is you can get a well-formed gland of pattern 3 that is kind of sliced off the edge of that well-formed gland that can mimic a poorly formed gland. And that's something every day I deal with. Are there truly poorly formed glands that we give a pattern 4, 3 + 4 = 7? Or is it all pattern 3, but maybe some of these glands have an artifact that mimics pattern 4? And that's where, again, I think a lot of it is experience. I look at different layers of the prostate biopsy to try to sort that out. And ultimately, with the way I practice is, if I'm not sure if something's lower or a higher grade, I typically give it a lower grade rather than give a person a worse disease where they're overtreated. Because if somebody's overtreated, you can never take that back. If they're potentially undertreated, you follow them, you can treat them down the road. But that can be a problem, and that's where the subjectivity of grading can come into play, and where, again, I think experience comes into play.
Thank you for that.
I have another African-American related question relating to an autopsy series out of Detroit, where there was a 30% rate of prostate cancer in men in their 30s. In the group, there's a significant number of African-American men. How does this number compare to the general population in your experience? And this is a citation from the Journal of Urology in 2010. So,
yeah, I know that. Weil-Sacker, yeah.
Yes, that's the one.
Yeah, so those are autopsy studies. So it's very important to distinguish autopsy cancer versus clinical cancer. So, if you looked at every man who's age 50, who, let's say, died in a car accident, and you took their prostates and put the whole prostate through, looked at it carefully under the microscope, 50 to 60% of them would have cancer. Prostate cancer. And if you took a man like 80, probably close to 90% would have cancer. Now, we're not having 50% of men dying of prostate cancer, and we're not having 90% of men dying of cancer. So most of these cancers are what's called, indolent latent cancers, occult cancers. They're just sitting there doing nothing. And that study, in terms of looking at cancers in men in their 30s and 40s, probably is an overestimation. It's clinical cancers are very, I would say, exceedingly rare in 30s. So the youngest man I've ever seen with prostate cancer is like 27. Like I've seen 1 or 2 of them. Cancers in the 30s, exceedingly rare. I do start to see cancers in men in their 40s. That's when I would say it's rare, but I start seeing them with some frequency. And then 50s, it becomes, not rare. But in terms of African American versus Caucasian, in terms of age, I wouldn't say there's a big difference.
Yeah, if I may ask another question, 10 years ago, I'm told that 6 to 10% of men went on active surveillance. There's been a surge in the last 5 years, and I understand in some programs they see, I don't know, 95% of men with very low diagnoses, go on active surveillance, and overall maybe it's 50 to 60% nationally. But if you flip that 50 to 60%, then something like 40 to 50% of men are still undergoing surgery, even though they have a Gleason 6. Can you explain what the failure is there?
Yeah, so I think that's, again, gets into what I talked about, the whole issue of trying to reassure patients, explain to patients, educate patients that once you are labeled with cancer, not all prostate cancer is the same. And that with close follow-up, and I think that's the key with the whole thing. We don't call it watchful waiting. Watchful waiting is very passive. It sounds like, we're just going to watch and wait, see what happens to you. We're not doing that. We're actively surveilling patients yearly, every other year, with biopsies, with PSA, with imaging. Again, it's not 100%, but nonetheless, we think we can do it safely for the vast majority of men. But there's still going to be some percentage of men who are just not comfortable, and that's fine. It's ultimately a personal decision. But I think we can educate patients, and at least for those that are comfortable with it, we can make them more comfortable with going on active surveillance. And I think the great thing about patients now, where patients are reading their pathology reports, they're going on the internet, they're trying to get information, they're attending conferences just like tonight, getting informed. And I think the better informed patients are, the better decisions they'll make, and more comfortable they'll be with their decisions.
Well, listen, I think we've gone over your 5 minutes. I want to thank you on behalf of 300 some people. They are applauding wildly, and they're very grateful. And we appreciate it.
Thank you.
We appreciate it.
That's going to beget another invite.
We're glad to help out in any way it's possible.
Thank you so much.
Oh, look out. Look out.
And so I guess it's Jim's turn now.
Yeah, we just, Jim and Peter will just have some quick closing comments for us.
Yeah, I just want to say thank you to Dr. Epstein for a great presentation. It's just far beyond my expectations, really. So, and once again, thank NCAN for this series and permitting us to partner with you this year. And I want to wish everyone a very happy and healthy and prosperous new year. Thank you.
Thank you.
Thank you.
Mr. Kafka.
So just in closing out, I just want to mention we use the acronym ancan.org. That's our website, ancan.org. We started out as the Answer Cancer Foundation. We're a nonprofit, and we're just a group of guys initially. All of us had prostate cancer and have it, who were passionate about educating, supporting, and being advocates for other men. And we still remain that way. We're an ongoing organization. We run, just for prostate cancer, we run some 14 support groups a month. Every week we have, much like the pathology of prostate cancer, we divide up our groups. We have weekly groups for advanced cancer, prostate cancer. We have weekly groups for active surveillance. We have a group for men under 60 addressing some of the special issues that they have for younger men. We run a group for low and intermediate prostate cancer. And now we use ANCAN, the term ANCAN, because we branched out beyond cancer and we're addressing some other serious diseases such as MS and many others. So look up on your website, ancan.org, and you'll begin to see where our meetings are. Anybody can tune in. It's free. It's drop-in. You can live in the most remote part of Montana, and you'll be there with a group. And presently, we're getting 25, 30 men weekly on a call. You might think that's hard to manage, but it's amazing. Everybody has a chance to address their concerns and be heard, and uh, and leave well informed. So thank you. This has been an excellent evening.
Yes, and I'd just like to add for Dr. Epstein, we had over 340 people actively on the call, which is about, I think, our max that we've hit before, because we also get a number of the international folks who will wait to see the video, and we'll definitely keep you posted on how that's progressing as well. So again, thank you all very much.
Appreciate it. Thank
And
you
if I
again.
could just ask the staff, as we get ready to say goodbye to the good doctor, if you guys will just hang on and as we let the attendees leave. But thanks again, Doc. We
My
appreciate
pleasure.
it.
Thank you.
Bye-bye. Have a happy new year.
You too. Have a happy.
You too. Well, I thought it was damn good.